Good morning. So it was only 2 years ago that I was a fellow here. So you could have moved a little bit closer because I'm not scary yet. Um, Training in a multidisciplinary ICU is the dream for an emergency doctor because emergency doctors don't have a lot of friends. Our emerge friends are fun because we're always out biking, but we're never really feeling like we belong when we're working in the emergency department, because my job is to give all of you unscheduled work, and nobody really wants that phone call. But working in a multidisciplinary ICU is the total opposite. Everybody wants help from their friendly intensivist. Whether you're a surgeon, an anesthesiologist, an emerge doc, a medicine doc, everyone leans on that ICU team. And so being able to train in a multidisciplinary place like Stanford was absolutely a dream come true. But it doesn't matter what discipline you're in. You were taught about adenosine triphosphate. We've all learned about adenosine triphosphate. I love adenosine triphosphate. When I fall asleep at night, I dream about adenosine triphosphate. And when I wake up in the morning, the first thing I think about is adenosine triphosphate. And I've been thinking about adenosine triphosphate since I was 16 years old as a lifeguard, jumping into swimming pools, pulling out people who probably shouldn't have jumped in to begin with. And then running through the streets with lights and sirens and ambulances, flying as a paramedic in helicopters, becoming an emergency doctor, becoming an ICU doctor. No matter what setting I've been in my entire life, everything around me has been designed to maintain ATP levels. A BVM is just an ATP machine, an anesthesia machine, an ATP machine. Almost every drug in the ICU that I can pronounce is an ATP machine. All it does is make sure that either air flows through a tube, your lungs ventilate and oxygenate, blood goes through your pump, through your pipes, into your tissues. That's all I care about, is whether or not my patient has ATP. In your body right now, there's about as much ATP as the weight of an egg. But today, your body will consume 150 kilograms of ATP. That is how much this caribou weighs. How do we go from an egg to a caribou every single day? Don't worry. I am going to spend 3 seconds on this slide. This is the very evil Krebs cycle. It is accompanied by the unshown electron transport chain. It is your ATP machine. How many times does this run every day to make enough ATP to turn an egg into a caribou? 170 septillion times. Don't count the zeros. That's the right amount. This is how many times your Krebs cycle goes to make sure your body has enough ATP to keep you alive. And if you stop producing ATP for a couple of minutes, you're dead. Let me ask you, when is the perfect time to die? No hands go up. I'll give you an easier one. When is the worst time to die? Most people have an answer for this. I've heard people tell me they are terrified of drowning. I've had people that they are terrified of dying while on fire. I've had some people tell me that they are terrified of dying alone. But most of us could imagine the worst way to die. This is my worst way to die. I would never want to die obtunded on machines with tubes and wires obscuring how I look, unable to appreciate the people around me. This might as well be Dante's Inferno to me. This is not how I want to die. But I am an intensivist, and I subject people to this very image in real life every single time I go to work. I didn't really feel a tension between life and death as a paramedic. Things seemed a lot simpler then. Sometimes people were rigored by the time I got there, and I was like, all right, nothing for me to do. But otherwise, they would get a standard ACLS algorithm, get thrown in the back of a truck, get dropped off in an emergency department, and then I would go and get a latte. But as I advanced in my career in emergency medicine and then in intensive care, I began to become a little bit uncomfortable with what to do once I had applied all these machines in good faith that I could get you better. And it became increasingly clear that that promise would not be fulfilled. And so I began to really recognize the tension between resuscitate and palliate. And I think this is a tension that a lot of you have probably felt. If you're a surgeon, you might say something like, I'm not even going to do that consult. There's no way I'm operating on that patient. If you're an anesthesiologist, you might have said, oh my God, we're going to put this person through that surgery. If you're an intensive care doctor, you might be like, how on earth did we let it go so far? We've all been in those situations. And a lot of the time, we'll say something along the lines of, I can't believe the family wants this. But I think as part of this tension between whether we ought to resuscitate or palliate someone, we also need to take a little bit of blame on our own culture in medicine. Because generally speaking, we put our foot on the gas because we need to make ATP. It's a compulsion. To not make ATP feels wrong for me. And so I offer a dialysis machine. I offer a mechanical ventilator. I offer artificial feeds. And I don't know that that's always the right thing to do. And so I started by asking myself and then my peers, is technology complicating the way that we die? So let's go back about 150 years and answer that question. 150 years ago, there was no technology. Mechanical ventilators have only been around for half a century. 150 years ago, we used to just die in our bed. Someone would get sick, then they would get sicker. Elders in the household would spread word through the community. Visitors would come and go. People would gather, and you would die in your bed. And everyone around you would watch that happen. And in dying amongst your family, you would teach others how to die. It became an expectation. It became just part of life. And then things started to change. It started in the mid to late 1800s when things became a bit more sanitary. This is Igor Semmelweis, an obstetrician who is Hungarian but worked in Vienna. And he noticed that about 1 out of every 6 women that he would deliver would die of childbed fever. No one really knew what childbed fever was. He would go down to the morgue and autopsy those women. Couldn't figure out why they were dying. Then he'd run back upstairs and deliver a few more babies. Maybe didn't wash his hands in between. And he was spreading streptococcus. He decided one day that he would wash his hands with chlorine. He wasn't a microbiologist. He didn't know anything about streptococcus, but he thought the smell of the chlorine might somehow prevent women from dying after childbirth. Turns out chlorine is also an antiseptic. And over the next couple of decades, hand washing and other sanitary measures meant that people were no longer dying of infections at young ages. Then we had Andrew Fleming, a rather lucky and lazy scientist who went away for vacation in 1928, leaving his petri dish uncovered, and came back to find that his bacteria had been killed by a fungus called penicillium. 10 years later, penicillin was widely available and is largely credited with one of the reasons soldier mortality was significantly lower in World War II as compared to World War I. Now we're entering the 50s. We have general sanitation, we have hand washing, and then the polio virus hits. And we develop these gigantic monstrosities called iron lungs. We produce them en masse using World War II's industrial machine. And we have gymnasiums full of iron lungs so that as polio grips onto your diaphragm, you can be supported for the week or two it takes for polio to let go, and then you can breathe on your own again. Before the iron lung, this was left to medical students with a bag valve mask, essentially, to manually ventilate you for 2 weeks at a time. And any anesthesia resident can certainly sympathize with anyone told to bag someone for any more than 5 minutes. It's not easy. So now we have technology entering the scene, antibiotics, sanitation, and this is sort of the birth of intensive care. Those giant iron lungs were miniaturized into positive pressure ventilators, like the green box that you see. The Vietnam and Korean Wars meant that a whole bunch of Army medics who were working in the war came back and needed jobs. And other technological advances meant that things like defibrillators, which used to be the size of a washing machine, became the size of a shoebox. So we had personnel and we had equipment. The only thing left to do was put them in the field in the United States. And the impetus for that was the growing popularity of the automobile, which was not accompanied by a popularity for seatbelts. And so in the 60s, we had an epidemic of trauma. And so ambulances, staffed mostly with Army vets, were deployed using machines that were novel. And we needed a place to concentrate all this expertise. And that was the intensive care unit. And by the early 70s, every hospital in America had an intensive care unit that had ventilators. And it was the heyday of critical care. Until we entered a gray zone. We would attach people to machines, hoping it would save their life. But then eventually, one by one, everyone around that patient would come to realize that that was not going to work. Okay, we're going to take a quick little time out. Something else was happening during the 60s and 70s at the same time critical care was establishing itself. And that was human organ transplant. So since like 50 years earlier, like 1905, I think was the first sort of experimental heart transplant. But it wasn't really until the 50s with kidneys and then the 60s with hearts that transplant was really starting to take off. And then in December of 1967 in South Africa, there was an upset. And Christian Barnard installed someone else's heart inside Louis Wyshansky. And he lived for 18 days. This was front page news. Everyone assumed Stanford would be first. And 32 days later, Dr. Shumway did catch up and did the first heart transplant in the United States. This was huge. Every newspaper in the world carried news of this. There was huge interest in how this occurred. It seemed like a miracle. There was also huge interest in this woman, Denise Darval, whose heart was placed into Mr. Wyshansky. There was a little bit of controversy about the status of Denise at the time her heart came out. It is generally agreed upon that she was probably brain dead, but we're not entirely clear how that diagnosis was made, because at the time, brain dead wasn't a thing. People just said, well, she's horribly injured. She doesn't breathe on her own. She's probably brain dead. The next year, when a Japanese surgeon, Dr. Wado, did the first heart transplant in Japan, he was not celebrated the way Christian Barnard was. He was thrown in jail for murder. And so the world went through a really tough time trying to figure out how to cope with this ability to transplant human organs. And so the need to define death became very pressing. Now, generally, we would all agree that when your heart stops, you're dead. Although, like how long can it be stopped for? It depends on if you're submerged in cold water or not. Over an hour? Over an hour and a half? We do that. In the cardiac OR, how long are you in standstill? Oh, you can do it for a long time and then come back. So really, your heart stopping is just a proxy for what we're actually trying to get at when we define death. And that is your brain cells not having enough oxygen and dying. And that's because your brain is where your person resides. And personhood in North America is the standard for being alive. So, irreversible loss of consciousness and the inability to breathe define brain death then and now. Now, we're not going to go through this too much because it would take me an hour to tell you all about all the various ways we've defined brain death. But you can see that every decade or so, it changes. And just last year in Canada, we changed the guidelines again. And right out of fellowship, I had to relearn how to diagnose brain death, which was super annoying. In the UK, it's a little bit different than it is in Canada, which is a little bit different than it is in the States. And then Stanford sort of had these extra little flavors in their policy just to really make sure we didn't screw it up. And so how we decide if someone's dead is not as black and white as the public might wish. And this is all because of solid organ transplant. You got to be dead for us to take your organs out and give them to someone else. Okay, unpause. We're going to put all of this together now. We have new technologies that can avert death. And if you do die, donation can follow. All of this is enabled by technology. And I could stop my talk right now and say, give up on anesthesia, come be a critical care doctor, super cool specialty. We get to use machines to keep people alive. I guess that's what you guys do too. But we have more machines. But actually, this is just the very start of my critical care journey. Because I think in some regards, we may have become too good at delaying death. I'm really good at making ATP. I'm really good at making ATP. But I've never had a patient's family tell me, doctor, please make more ATP. When we're in the ICU, stuck on organ support, we often talk about pulling the plug. And how we do this is highly variable. It's open to a lot of bias, and it's open to a lot of tension for our nursing colleagues, for our physician colleagues, and for our families. And I was losing sleep over this. So I decided to put my narrative background to work, and I wrote a book about it. And I'm going to spare you having to read it and just give you the punchline. I spoke to dozens of people while writing this book to try to figure out what are we going to do about this dilemma of dying on technology. I spoke to a historian who said it really is technology's fault. Before technology, people just accepted that the end was coming, and they just went into the good light. So this is truly a modern phenomenon of the last 60 years. I often in the ICU am told that there's some religious imperative to keep people on life support. But when you go to the heads of most religions, you find that that's not entirely true. There are no religions that expressly prohibit withdrawing life support. But many people have a perception that withdrawing life support goes against their religious values. Sociology also plays a role in this. The sociologists that I spoke to basically blame Twitter. They basically blame social media and this habit we have of always looking at our cell phones. Because in doing so, it reinforces this ego in ourselves that we are important, that we are right. And it kind of gives us this sense that we're entitled to almost everything, including life. And so the sociologists describe a lot of the tension that we face in the ICU as being one about ego and privilege and just not being willing to accept that the end might be near. I spoke to a lot of ethicists thinking that they would have the grand solution to this struggle. And it turns out that ethicists rely quite a bit on local regulations and laws in determining their path forward. And so ethicists in New York told me different things from ethicists in California, who told me different things from ethicists in Toronto. And it became clear that the ethicists were struggling with this the same way that I was. Early in my residency, there were a couple of cases that had ended up in the courts. These were people who were diagnosed as brain dead, but had gotten injunctions to keep people on life support. There was one case, Takesha McKitty, a 26-year-old, who was pronounced brain dead and was kept on life support for 416 days until her body collapsed, and everybody agreed at that point that she had died. In those 416 days, we did not receive a judgment from the courts. It was just working through court date after court date after court date. So the courts are not the place to solve this problem. And so lastly, I ended up talking to an old timer, Ron Stewart, who had been a physician for 55 years before retiring shortly before I spoke to him. And he described a pendulum swing. I said, like back in the 70s, like this wasn't as much of a problem, even though we still had machines. And he said, well, Blair, back in the 70s, you would just turn off the machines when you knew they weren't going to work. There was almost exclusive physician autonomy and physician trust with families that when the doctor said we had tried hard enough, we had tried hard enough. Nowadays, that pendulum has swung so far in the other direction, we're starting to have debates about, have we gone too far in the autonomy that families have when deciding if we continue to add machines or not? So at the end of all of these conversations, I came up with an equation that you need to have technology, and that when you add these two components, you get the death dilemma. The first is on us. It's resuscitation glorification. It's this idea that ATP is at the top of the pyramid. Nothing is more important than keeping you alive. And when we add that to the death denialism that seems pervasive in our modern society, we have both families and doctors operating almost outside of reality as they push ahead further and further and further into a miserable place. So it's not that simple. There's an elephant in the room that, of course, we need to address. And that elephant is prognostication. In order for me to recommend that we not add machines, or even that we turn off some machines, I have to be reasonably certain that I can predict the futility of those machines. And we think we're really good at this, but we're not. I don't care if you've been in practice for 40 years or 4 years or 4 months. We are really bad at prognosticating. And what we know from the literature is that prognostication, in addition to just being bad at it, we're very biased at it. And you can imagine the racial, gender, age, and ableism components that might seep into a decision to recommend against, say, dialysis, to recommend against intubating a patient who's had a stroke, to recommend against CPR. But we don't really talk about it. We kind of just come up with a plan together or solo, and then we send these weird messaging vibes to families, and we hope they don't fight us on it. And then if they do fight us on it, we kind of get our backs up. Everything goes toxic, and we have to call ethics and risk management. Then a lawyer shows up. And that's when I think we have completely failed. When a lawyer shows up to help us decide what we ought to do with our medical abilities. But at the same time, when death is off limits, when no one is even willing to flip the switch or discuss palliation, where does that leave me? I'm happy to talk about the uncertainty of my prognosis, but when families don't even want to hear it, when families just say, we know what you're about to say, don't say it, keep going, where does that leave the room for conversation? Well, at the end of the day, it's all an emotional question. Families are rolling the dice. We say something along the lines of, there's only a 1% chance that this will work. And families say, 1%? That sounds great, because the alternative is death. And so they roll the dice. But we're not good at explaining what the alternative actually looks like. Because sometimes it's not death. Sometimes it's an existence that many of us would never choose for ourselves, an existence worse than death, and that's being tethered to machines. So while families are sort of gambling on life, physicians are just playing a chess game and say things like their white count went from 28 to 26, or their lactate went from 18 to 16, and they say it as if they're winning. But I don't know that a lactate going from 18 to 16 means anything at all. And I certainly don't know what a white count going from 28 to 26 means. But we focus on these micro improvements because we're playing chess, we're playing chemist, we're trying to make ATP. And if your lactate went down 2 points, well, that means your ATP factories are kicking back in. When really, we're within the lab margin of error. Because I was trained. ATP is the only thing that matters. ATP is life. But that's kind of bullshit, isn't it? ATP isn't life. All of us have lives. Most of us would say that the most joyful part of life is outside of a hospital. We have families, we have friends, we have hobbies. We have a life of experiences. Kids and brothers and sisters and aunts and uncles. That's what makes up someone's life. But in the hospital, we're stuck on those micro improvements. We are so in our heads as physicians, while families are so in their hearts, struggling with potential loss. We are speaking two very different languages. We're on different tracks. And in order for the right thing to happen for a patient, those tracks have to merge. And that simply takes time and talking, both of which are in short supply. We just don't have time to have these conversations. We're not comfortable talking to families about uncertainty. Families aren't comfortable talking to us about the potential for death. And so this is sort of how my book concludes, that how do we get on the same track? How do we merge the mind and the heart on the two sides of this conversation to really understand when the game is up after technology has been applied? And 2 months after my book came out and hit the bestseller list, I ended up in Sunnybrook Hospital, which is Canada's Stanford, where I had taken my dad when he was diagnosed with metastatic pancreatic adenocarcinoma. And I know what metastatic pancreatic adenocarcinoma means. People who aren't doctors know that pancreatic cancer is terrible. And my dad, in a bit of a witty way, said, well, it's a good thing I've read your book because it looks like I'm about to die. And I said, oh, no, Dad, hang on. And I got on the phone and I got on PubMed and I lost it. I went down a rabbit hole. I was calling people at Stanford saying, okay, so like, what's the most expensive novel therapeutic study that I can get my dad in? I was going absolutely off the deep end, trying to save my dad's life. And I realized, oh, I've become the crazy family. And so I went through a bit of a journey to come to the palliative conclusion. Fernando and I decided that we would rush our wedding. And so we planned for a wedding 2 days before Christmas, 3 weeks after my dad's diagnosis. The only place you can get a venue around Christmas is at the Toronto Zoo, which was a place that we loved visiting. And we had always joked about getting married there, but now corporate Christmas parties had booked out everything else. So we ended up getting a booking at the zoo. And the night before our wedding, my dad called me and said, "I'm vomiting." Okay, Dad, well, I know this is probably a gastric outlet obstruction. You need to go to Sunnybrook and get a CAT scan. So 4 hours later, I got a phone call from a hepatobiliary surgeon who said, we need to do a JG bypass. And I was like, all right, well, I guess we do it. My dad was like, what does it get me? I'm like, it gets you not aspirating to death. He's like, oh, well, that sounds worth pursuing. Okay, great. So I talked to the surgeon and I said, I'm getting married in the morning. Is there any way? He goes, oh, well, how would I book the OR for 3 p.m.? And so at 9 a.m., the surgeon put my dad in a taxi with an NG tube in his nose and a pocket full of 60 cc syringes. And my dad was able to come and officiate my wedding. And that is what medical technology can do. Medical technology created this photo. My dad lived for 5 more months. And as an intensivist, before my dad was diagnosed, if someone called and said, hey, I have someone in the ER with a gastric outlet obstruction for metastatic pancreatic cancer, I would say, you have the wrong number. You can't, surely you're not looking to admit this patient to an intensive care unit. But had my dad aspirated and needed 3 days of high flow, or had he had a line infection with E. coli bacteremia and needed 72 hours of Levophed, yeah, bring him to the ICU. Because I'm getting married soon and he needs to be there. So I have, after writing this book, ended up on the other side of that equation. And the only conclusion that I can come to is to steal a line from my medical school interviews at McMaster over a decade ago, that no one should die too early. And that's why I want to be an emergency and ICU doctor. But in that process, it's our responsibility to make sure that no one dies too late. And finding the sweet spot will be the challenge of my career. Thank you so much for having me.
Thank you, Blair. Thank you, Blair. That was very thought-provoking. Any questions from our audience? Okay.
Wonderful. Thank you so much, Blair. Do you have how to get started? Do you have some concrete tips for us? I mean, I agree with you. I don't think we sit down early enough, and it's hard because, now we only work 7 days because we're just too tired. So do you have anything that are there ICUs that do this really well? You've practiced a lot of different places, like things that everyone should do, and then there are nuances on top of that?
Yeah, I think right now, like it or not, we live in a low trust society. And if I'm going to make a recommendation for or against anything in healthcare, whoever I'm speaking to needs to have a little bit of faith in me. I work in the poorest part of Toronto with a lot of refugees, a lot of immigrants, a lot of people who don't look like me. And I think to get started, it doesn't have to be a sit down, because if you schedule it, there's something a little bit phony about it. You get a social worker beside you who does the heavy lifting. And what I do is when I'm walking around the unit, if I see a family member, I go and I say hi. I just say, how's it going? Thanks for visiting. We're so happy you're visiting. We love having visitors here. And then over time, I'm thinking of these two tracks merging. And you can't really force it, but you can accelerate it by just having these conversations to build trust so that the family sees what you're emotionally going through as you try to save someone's life, so that they see you go from resuscitate to palliate in your own mind. And I've had families say, today's the first day that you've sounded sad. And I'll say, that's a good observation. I'm feeling sad today and I wasn't yesterday because I'm seeing us lose this fight. And so when you go on the journey with that family transparently, with lots of little 2-minute touch points, I think that they see that effort from you, so that when you do go and potentially make a recommendation to not use machines, they know that the loss that's going to occur is your loss as well. And other things are to use words very carefully. And I know that there's lots of courses on how to talk about death and dying, and there's lots of scripts out there, but I'm very clear with families when we're using technology. And that could be something like a central line or artificial feeding. It doesn't have to be a big boxy machine. But I think the more you talk about how technology and life support is keeping this person alive, then the easier it becomes for families to say, well, let's not use technology. It's not giving up. It's just deciding that machines are not part of the plan. And I find that using that kind of cold language of machines and technology helps people realize that they're not abandoning medicine. We're still there to care for you. We're just not going to use these machines that delay the inevitable. And so those are my 2 tips. Every time you see a family member, like, just go say hi to them. Even if you're like, oh God, and like you want to run, like you have to lean into it. And you can say, I'm just on my way to a meeting, even if you're not, but I just wanted to stop and say, I'm so glad you're visiting. And I'd like to speak with you more later. But just those little touch points humanize the connection that we're making. Because if we don't have that trusting relationship, we're really in trouble. And anesthesiologists are really good at like building this trusting relationship in like 3 seconds in pre-op, right? Because like they've never met you before and you walk in and say, I'm about to put you to sleep. And people are like, cool. Like, how do you get that trust in 3 minutes? They just trust you so much. In the ICU, that trust is not as quick. It takes more time to develop. And it's all about touch points.
I wonder, Blair, thank you for those two suggestions. Sometimes there is also an underlying tension between providers themselves. And yesterday during dinner, we were speaking about the tension between, for example, a nurse whose moral prerogative might be, let's diminish suffering, let's make sure that people are comfortable, versus a surgeon or an intensivist whose moral prerogative might be survivor. Let's just keep this patient as long as possible. And that might build some issue, some tension between the nurse at bedside versus the intensivist or the surgeon. How might you manage that tension between providers?
The first thing to note is that when nurses and physicians agree that prognosis is poor, they're much more likely to be correct than if only a physician thinks that prognosis is poor. So leaning in on your nurses for that assessment, especially your experienced nurses, is worth its weight in gold. I have never spent 12 hours with one patient in my entire life. I never want to. I like to move, right? Like, I have a 17-bed ICU and I'm going to just chug my way through that list. But a nurse is with that patient for 12 hours, maybe 4 shifts in a row. And they are so involved with the body that they're taking care of. They're turning that patient, they're doing mouth care, all of these things that they might perceive as being horribly uncomfortable. And so their perception of suffering is much more attuned than I think any physician has the ability to recognize. And so I think sometimes the nurses can see the forest through the trees. When we're looking at micro improvements in a computer in an office down the hall, they're sitting there going, we got to stop doing this. And I think if a nurse signals to you that, like, we just can't keep doing this, this is awful, it's time to sit down and reflect. Whether you're a surgeon or an intensivist, surgeon, I'm not a surgeon because I don't have the guts to be a surgeon. Like, to apply steel to somebody electively, like, I can't do that. The burden of that would be way too much for me to bear. And so I have a huge amount of respect for surgeons who, like, I couldn't even do an elective gallbladder, let alone like go and take out half of somebody's liver because it's riddled with cancer. The surgeons who deal with these life-threatening cases that often come up in the ICU are on a caliber that I can't describe. They're just incredible artists with the way they cut. And I admire their prerogative of like, I'm going to take ownership of this procedure. I want this person to do well. And it can be hard sometimes for me to share my different opinion about where things are going. But just like families are going on a journey and we're going on a journey, I think surgical specialists are also going on a journey of, you know, after the kitchen sink, what comes next? And we can walk that journey together. And we might be at different places, but eventually, again, everybody's going to come to the same conclusion if we just keep talking about what we're seeing. And sometimes surgeons will tell me something that I'm not seeing. And they'll be like, no, like, this is what I saw today. And this to me signals organ recovery. I'll be like, oh, I was not seeing that. And so then I have to have sort of a healthy appreciation and skepticism of what that might mean for my own prognosis, recognizing that we're all really bad at prognosticating. We've all had people walk out of Stanford who we would have sworn off. We would have, like, I would have bet my house that this one guy in J2 was never walking out of here. And then he literally danced out in front of me. And I was like, oh my God. How many times did I tell his son that, like, this wasn't going anywhere? Yeah.
There's a couple of questions in the chat, Blair. One of our listeners was wondering, how does death in developed countries compare to death and dying in other nations?
Yeah. I have limited experience working internationally. In residency, I spent about 6 months in Southern Africa and Eastern Africa. So there's two components. The first is the technology component. And a lot of places who don't have a lot of resources just don't have the technology. And so it's not even an option. It's kind of like when people died in their bed 100 years ago. You didn't have the technology. And at first, that's very jarring for somebody coming from a very expensive healthcare system to feel like you can't do what needs to be done. But there was also, because death is more common in places that have less resources, there was more of a respect that death might come. And so people never said to me, well, send them to Kampala for like better care, or send them into Cape Town for better care. There was just this acceptance that you do what you can do, and if it doesn't work, it doesn't work. And that's a mentality that was, in a way, refreshing, having worked in places where you almost feel like you're being attacked by families, pressured by families to do things that you don't think should be done sometimes. And I don't know the literature around this type of topic from a lower resource setting, but my experience in Southern Africa is very, very different, obviously, from my experience here. But people weren't craving technology. They weren't asking for more. If anything, they were like, well, doctor, like, they're dying. Like, can't you tell? And I'm like, well, yes, that's why I want to. And they'd be like, well, no, like they're just dying. And so that would be a generalization of my short experience working in Southern Africa. Yeah.
And obviously here at Stanford, we see a lot of patients and families coming from different cultures as well. Like in your experience, how does the culture background and their belief system affect how you talk to them about death and dying?
Yeah, that's a really good question. And I'll try not to take up your entire day with my answer. But generally speaking, I don't approach families all that differently right off the bat, because I don't think we can generalize. You know, like where I work, people would say that a Sri Lankan family post-arrest will never withdraw care. And that is absolutely not true. But that's the local belief in that hospital. But if you work with that family and get to know that family, I find that often they will choose not to pursue a prolonged hospitalization after a critical illness. I think what happens is, because I'm not Sri Lankan and I don't speak Tamil, I have lesser quality conversations, less frequent conversations with families. A lot of families that are culturally different from me are bigger. Like there's 8 of them there for the family meeting instead of 2. And so more consensus needs to occur. Refugee and immigrant populations have lower trust in health institutions for a number of very legitimate reasons. And so it takes more effort. And so a whole bunch of things start to compound, takes more time, there's more people, needs more consensus, needs a translator. Maybe we don't feel comfortable talking to a family that doesn't speak our language, or maybe that family doesn't feel comfortable necessarily challenging us. And so they just defer, or they seem to accept what you're saying, but in private circles are having a different conversation. And so it just means that you need to lean in even more to build that trust and to walk on that journey to come to an answer that's suitable for the family. And it also means letting go a little bit of your ego. Whenever I walk into a goals of care conversation, I have to remind myself that I'm not after a certain outcome. Because I've walked out of goals of care conversation and said, oh man, like I totally screwed that up. Oh man, I'm never going to get the withdrawal. But it's really not about me. It's about what's best for that family. And if that family chooses trach and peg and a life of anoxic brain injury, you know, that is their choice. Where I work, it's not their choice in some US states, for example, where a hospital might withdraw. But where I work, my hands are tied. And so I don't have unilateral options where I work. And so I either just like throw my hands up in the air and go, all right, fine, send them to the back hallway, which is our LTAC. We call it the back hallway. It's unrenovated and looks dingy, and that's where all the chronics go. But I think the opposite approach to that is to say, well, I just need to invest even more time. The problem is, like, investing time in families is not something that I get compensated specifically for. It's not something that I always feel like I should have to do, like they should just trust me. And it's not something that I always feel well equipped to do, because it can be very awkward speaking to people who are of a very different culture than you, especially when there's a language barrier and you have a translator. The conversation's just not the same as when I walk in and talk to like Betty about how Norm is dying. Like, that's a different conversation. Oh, doctor, you're very cute and thank you for talking to me. I understand. That's just different. Betty trusts me instantly. You know, Betty being like this cute little white lady that you can all kind of imagine looking like my grandmother. That's just a different conversation than when I'm trying to talk to Srimalar and I can barely pronounce her name when I look at the sheet and I'm like, oh, Sri, is it Srimal? You know, like, it's a harder way to engage somebody. You just have to be better at it. At my hospital, one of the things that was a real pet peeve is that anybody who had a Sri Lankan last name would just be called Mr. C or Mr. S. And I said, guys, like, we got to learn how to pronounce these last names. Like, ask the family, work on it. Like, families are very gracious if you're trying to do that. But showing families that type of investment and respect, I think, builds that trust as well. It's a super tricky question. But again, to Angela's question, you just have to invest time in it. I guess a grand solution is to find out how to incentivize doctors to spend that time, right? And maybe it means that you have specific teams of people who give updates or something like that. I haven't seen a great model for that. There's been some efforts to mandate palliative care visits in the ICU, but those kind of get a little bit messy because again, what is the prognosis here? Just like a surgeon has a toolkit, palliative care runs around and just wants to palliate everybody sometimes because they're like, well, that's what I do. I'm here to palliate. You look miserable. Let's palliate you. And so I think that there is sort of, we're all just out there with our toolkits trying to do the right thing. But we also need to recognize that we have all of these biases and blind spots. And that's why this is such a tricky topic. We got to end on a more positive note than that, though.
Well, and on that question, thank you, Blair. And thank you for everyone staying a few more minutes for these questions.
Thank you for such a great lecture. I think one thing that I've seen a lot is the big swings with, when people are family members are seeing the trauma of what their loved one has experienced and not wanting us to give up on them.
Yeah.
What techniques or what language do you use to, help a family understand that we are trying to align with them? I think I've seen people oftentimes use almost violent language to get across that this is futile.
Yeah. So I would advocate against things like, well, CPR breaks their ribs. Cause okay, so a broken rib, but who cares about a broken rib? I'm an emergency. People have broken ribs all the time. I send them home, right? They don't even get admitted. So I think sometimes we do try to dramatize what the end might look like. And so I do two things. And I think these are good tips. If you're still around or if you're on Zoom, these are two really good tips. The first is to stand at the foot of the bed with whoever you're talking to and say, what do you see today? And they'll say things like, they look terrible. They look pale. They look gray. They've lost a lot of weight. And then I just validate whatever they've seen. I say, I'm seeing that too. Sometimes families say their heart rate is faster. I go, their heart rate is faster. Yes, you're absolutely right. I'm seeing that too. And so I try to go away from the labs. People say, well, what's their creatinine today? I go, what do you see? Let's look at the person here. And sometimes they pick up on these, or you can pick up on things they say. And it allows you to introduce that you're right, this patient is getting worse. You see that too. I see that. We all see that this patient is getting worse. And just acknowledging that family member is going to go away and send some texts and be like, oh, they're actually getting worse. And then somebody on the text chain is going to say, oh, are they did the doctor say they might die? Should I get on a plane? And then the other thing that I do is I say, in the ICU, I have a lot of hope and I'm working very, very hard to get your loved one better. But sometimes in the ICU, people die. About 1 out of 5 people who come here will die. And so I want to ask you, would it be very important for your family to be present when somebody dies? And if they say, yes, we absolutely must be here when they die, then I say, just so you know, death is very unpredictable here and it can happen in the middle of the night. But if it's very important for your family to be present, then we can, and I say it just like this, I say, this is a bit awkward, but we have an opportunity to decide when to stop using the machines. If we use the machines, the timing of their death is uncertain. If we stop using the machines, I think they would die within a few hours. And so sometimes families don't buy into that, but it lets them know that like death is coming, whether it's on machines or not. And if it's really important that you're here, we can actually do that. And if people lean into that, then I say we can have music, we can have balloons, we can have photographs, we can go outside to the courtyard. We can do all sorts, you can bring the dog, whatever's important, we can honor in this very odd, awkward opportunity we have to time the removal of the machines. And some families just instantly begin basically planning for the pre-funeral kind of and they're just like, oh my God, okay. The other thing that I'll sometimes do is, and I call it my shot across the bow. I say, is there anybody in Vancouver or Boston who would need to fly here to see him? And sometimes families go, oh, oh, it's serious. I'm like, how did you not, like, it's been 5 days of me telling you they're gonna die and you still haven't clued in yet. But the flight question, you know, who would need to fly here quickly? Like, where are people coming from? Sometimes opens families up to like where you're at and can help them understand the gravity of the situation.
All right. Well, thank you guys. I think Blair's going to hang out a little bit longer. Everyone, ask him personally. Appreciate your engagement. And thank you, Blair.
Thank you.